you guys. In this lesson, we are going to be talking about asthma. Asthma is a chronic inflammatory disease of the airways, and it is a diagnosis you're going to see tons of during clinicals. So let's get started and learn all about it. Okay, so like I said, asthma is a chronic problem, and it's in the airways, and it's because the airways are heightened in their reacting. So all this means is that when someone who has asthma, when their lungs are exposed to a variety of different triggers, their lungs actually overreact. So they become inflamed, they have an increased amount of mucus, and they actually have bronchospasms that occur in the lungs. And you can see in this photo here, you have this is a normal airway, and then over here you have the asthmatic airway where you can see there's increased mucus, and that airway is actually becoming quite a bit smaller. So the amount of area that the air has to pass through is really tiny in the asthma airway compared to this normal airway here. And when this happens, you end up with airflow being obstructed. And when this happens, it's called an acute asthma exacerbation. And if this kind of obstruction and exacerbation happens really frequently, you end up with scarring and damage to the lungs, which is actually called airway remodeling. And the reason that we want to manage our patients' airways and their exacerbation so well is so that when they become adults, they don't have problems with scarring and all these long-term damage to their lungs. Triggers for asthma exacerbations are going to be different for every single person. And here's an actually really easy way to remember the most common triggers. So just use this mnemonic device here. So we're going to use asthma. So A is for allergens. So things like pets and pollen and dust, all those things would be allergens. S is for sports and smoking. T is for temperature, so extreme temperatures, hot and cold. H is for hazards, so chemicals and irritants that are going to be upsetting those lungs. M is for microbes. Microbe just means that infections can actually trigger an asthma exacerbation. And then last but not least is anxiety. So just always remember that anxiety can actually worsen or trigger an asthma exacerbation. Now, the diagnosis of asthma is actually based on clinical symptoms and the patient's history. So diagnostic tests are actually less important, but we can use spirometry to help us determine if our medications are effective for treatment. And then we also use something called a peak flow meter to help patients assess for themselves how severe an asthma exacerbation is. Now, a peak flow meter is actually, it tells us how much air a patient can forcefully push out of the lungs in 1 second. So what we do is when a patient's asthma is well controlled, we'll have them use the peak flow meter to establish their baseline. And this actually gives us our goal. Now, if they check their peak flow and they are 50 to 79% of their baseline or their goal, they're in this yellow phase here. And that means that they should be cautious and that they could possibly be having an asthma exacerbation. Now, if they take the peak flow meter and they are less than 50% of their normal, they are in this red here, and that signals that they have a severe airway narrowing and they need to do something quickly. For your nursing assessment, when a patient's having an acute exacerbation, what we're actually looking for are signs that their airway is being obstructed. And the first thing that patients may complain of is feeling short of breath. So they're breathing, and they can't seem to catch their breath, and they may not be able to speak in complete sentences. So if you see that, that's actually a red flag. So if they can't speak in complete sentences, that's a sign of a very, very severe asthma exacerbation. Another thing patients are going to have is a cough. It's usually a hacking cough and probably non-productive. If the patient's old enough to, they may be able to tell you that they feel like their chest is really tight, and they're going to be working extra hard to move air through their lungs. So you're going to see signs like retraction and nasal flaring. Now, the telltale sign of asthma is this here, it's the wheeze. So when you listen to their chest, and you may not even have to use a stethoscope, you're going to hear that wheezing sound, and it's an expiratory sound. And you hear that sound because they're having to force air out and through those really narrowed airways. Okay, one really important thing to know about listening to an asthma patient's chest. If you put your stethoscope to that chest and you don't hear anything, you don't hear air moving, you don't hear a wheeze, nothing, It's called a silent chest, and this is a medical emergency. And this means that the airways are completely obstructed and no air is moving at all. And this is usually a sign of something called status asthmaticus, which we're going to talk about in just a second. But just remember, if you listen and don't hear anything, it's an emergency. All right, so your treatment of an asthma exacerbation is always going to start with ABCs. Now, it's really important to not forget the simple things that we can do that really help our patients breathe. So elevate the head of the bed, provide suction if their nose is blocked, and try really hard to calm or distract the child, because remember, anxiety can make their symptoms so much worse. And these simple things can actually make a huge difference. Most kids are going to need oxygen, and this could be through a nasal cannula or a face mask. And then the next thing you want to get on really quickly is giving them some albuterol. Albuterol is a short-acting beta-adrenergic agonist, and what it does is it actually relaxes that smooth muscle in the lungs, and this relieves the bronchospasms and helps open up those airways, and you'll be amazed at how quickly you see patients experience relief from this medication. Now, don't just rely on them feeling better. Make sure you also auscultate the chest and listen and reassess to make sure that that wheeze is diminishing and you actually hear air moving through those lungs. Next thing to do is they're going to need systemic corticosteroids, and this is either going to be given PO, IV, or IM, and they're actually going to take these for a couple of days to help them get control of that inflammation. Now, if the patient does not respond to treatment and you hear that silent chest that we talked about, again, this indicates status asthmaticus. It's a medical emergency, and you got to get a provider to the bedside as soon as possible, because additional medications are going to have to be added to the treatment very quickly. So they may add Atrovent to help open up the lungs, and they may add that to the inhaled albuterol. And they're also probably going to give magnesium sulfate through the IV, and it's a very intense muscle relaxant that's actually going to help their breathing a lot. So now that we've talked about how we're managing acute exacerbations, let's go on to talk about how we help these kids manage their asthma every day and actually prevent these acute problems from happening. All right, so remember, asthma is a chronic condition, so we have to manage this illness all the time, not just when they're in the hospital. And long-term management actually starts with assessing the child's environment so that we can minimize their exposure to those triggers that we talked about. So these things are going to be like keeping a house clean, not having pets, and avoiding secondhand smoke. These are some of the things that we would commonly advise. Now, to reduce inflammation on a chronic basis, patients are going to be prescribed an inhaled corticosteroid. And the most important thing to note about these inhaled steroids is that they have to be taken every single day. And this is regardless of symptoms. And this is important because it's different than the other inhaler that they might have as a prescription. The steroids have to be taken daily. Now, that other inhaler that I mentioned is going to be probably a beta-adrenergic agonist, and that's albuterol. So they may have a prescription for that, which is going to be given through an MDI or the metered dose inhaler. And most kids are actually going to also need to use something called a spacer. The spacer helps kids manage the MDI because MDIs are actually really difficult to use, and kids have a difficult time getting the timing right. So a lot of times, it's very important to make sure kids are using the spacer, and we'll talk about that in just a second. So the albuterol inhaler is often referred to as a rescue inhaler, and that's because they're only going to be using it when they're symptomatic. So the albuterol is a rescue inhaler. They're using it when they're symptomatic, but the steroids are used daily. Now, like I said, other medications can be added. So we might see that patients are going to have long-acting bronchodilators to help with exercise-induced asthma, or they may have leukotriene modifiers like Singular to help with allergies. But these things here are going to be your first steps in managing asthma. Now, if a child is having to use their bronchodilator more than twice a week, or they're waking up with a nighttime cough, or they're being seen in the hospital every other month, we know that their asthma is not being controlled properly. Now, if they are poorly controlled, the first thing you need to check is their compliance. Are they avoiding allergens? Are they taking their steroids daily? And are they using that inhaler and spacer correctly? If not, then they probably aren't getting that medication into their body. So you always need to double check their technique for the inhaler and the spacer. We've actually linked to a video in the resources that goes through the entire patient education process for the NDI and the spacer use. So definitely check that out because it's a really important thing to be able to talk to patients about, and it's also very testable. When you're taking care of a peds patient who has asthma, your priority nursing concepts are going to be oxygenation, gas exchange, and then health promotion. Remember, we want to be preventing these exacerbations from happening. So that's our health promotion bit there where we're teaching and making sure parents and patients are compliant. All right, let's recap and identify those most important things for you to know for this lesson. So asthma is a chronic disease where essentially the airways are overreacting to stimuli. And this causes those airways to get smaller, to spasm, and fill up with mucus. And this is called a patient having an acute exacerbation when that happens. Common triggers for these exacerbations are allergens, sports and smoke, extreme temperatures, hazards, microbes, or infections, and then also anxiety. Okay, so the symptoms you want to be aware of with an acute exacerbation are wheezing, chest tightness, a cough, that shortness of breath, and remember looking to see if patients can speak in full sentences. And then don't forget also that a silent chest means that no air is moving, and this is a medical emergency. Your acute management is going to start with ABCs, then you're giving oxygen, bronchodilators, and a systemic corticosteroid. Your long-term management is going to be focused on decreasing exposure to triggers, reducing inflammation with those inhaled corticosteroids, and then albuterol inhalers are prescribed to help manage those exacerbations that they're having at home. And always remember, compliance and patient education are key. That is it for our lesson on asthma in our pediatric patients. It is a big topic, guys, so make sure you check out all the resources that we have attached that are going to help you put it all together. Now go out and be your best self today, and happy nursing.